Tamal Vitana. He's the consultant cardiologist at the University Hospital, General Sir John Kotalawala Defence University. And he'll be talking about complications and management of acute coronary syndrome.
Good morning, everybody. First of all, a big thank you to the College of Cardiology for continuously organizing this Allied Health Sciences program, which is a very, very important aspect of cardiac care, as our president just mentioned. And I also thank the organizers for giving me the opportunity to make a presentation today. So before I move on to the lecture, I'll just to wake you up from a bit of a pre-breakfast or pre-tea slumber, I'll pose a bit of a case. A 72-year-old man with a history of hypertension and diabetes presented to the emergency department with an anterior STEMI. He was thrombolized 1 hour ago and is currently stable. So what Dr. Sumudu mentioned all about emergency management, that has now been done. 1 hour post-presentation, he is currently stable. First question, where should this patient go for further management? And do you anticipate any problems? So with that, I'll move on to the lecture. So just think about the question that I posed, and by the end of this presentation, you should have a proper, a comprehensive answer for the question. So we'll talk about the functions of the heart, a little bit about ACS, you already know about it. The previous speaker spoke about it. Then how the acute coronary syndrome affects the various functions of the heart. This is important to identify the complications. Then complications of treatment itself. How to identify complications early. When should you be concerned. Initial management of complications in brief. And how to prevent. I'll go through this quickly in the interest of time. So functions of the heart, basic stuff, but important for us to remember because we can work most of our complications out if we know all the individual functions of the heart. So the most important thing is acts as a pump. It's what maintains our circulation. So this is maintained by the contractile function of the myocardium. The contractile function of the myocardium is guided by the heart rhythm, and therefore there's a very important electrical function of the heart. Then there's heart valves, which maintains uniflow within the heart and maintains the circulation. Then there is the walls of the heart, which keeps the blood within the heart, and the structural integrity is maintained by that. And then there's the pericardium, which also provides protection and is important for the function of the heart. ACS is ischemia or infarction of the regions of the heart muscle due to reduced blood supply, which is usually caused by atherosclerotic plaque rupture or thrombus formation. We saw that in a beautiful animation a little while ago. So what does this cause? This causes, in other words, the heart muscle is deprived of blood, and therefore it causes derangement of all the functions of the heart that we mentioned earlier. Reduces the contractility of the myocardium. That causes the efficacy of the heart's pumping action to go down, leads to acute heart failure. Affects the cardiac rhythm, causes arrhythmias. Affects the heart's valves, that causes valvular insufficiency. The structural integrity of the heart is sometimes compromised due to the ischemia. Due to an ischemia, if it's very bad, infarction of a large area can lead to myocardial rupture. Later in the course of events, there could be residual inflammation on the myocardium and the pericardium, and that can lead to pericarditis and a post-myocardial infarction syndrome. So I've put the complications in this way just for ease of remembering. So early on, almost with the presentation of a MI or of a heart attack, you can have acute heart failure. Like Dr. Sumudu mentioned, patient may come with SOB, maybe in florid pulmonary edema at presentation itself. Patients may have gone into cardiogenic shock with low blood pressure. May already have heart rhythm abnormalities or may evolve into having heart rhythm abnormalities such as bradycardia or other tachyarrhythmias. There will be valvular dysfunction, even perhaps at the onset of the MI itself, but usually takes some time, but certainly within the first 24 to 48 hours. An important complication, ruptured myocardium, again, an early complication, and you should be aware of it. And another complication is that a re-MI or a repeat myocardial infarction. So we all know that in the first few days or first few hours to days, the risk of a second myocardial infarction is very high, and that risk goes down as time goes on. Late complications include the aneurysm formation, mural thrombosis, and the post-myocardial infarction syndrome. So I won't touch too much on those. I'll touch mostly on the early complications. Acute heart failure is one of the most common complications. If you have ever worked in a cardiology ward, a CCU, a cath lab, or medical ward, I'm sure this would have been your bread and butter. Everybody, all of us, whether we are doctors or allied health science professionals, should be able to identify a patient who's going into heart failure. Risk factors would be an extensive MI, if there's a bigger or large area of the myocardium involved, previous history of heart failure, diastolic dysfunction, hypertension, diabetes, so on and so forth. And then this heart failure can lead or sort of get aggravated and go into cardiogenic shock, respiratory failure, and cardiac arrest. Cardiogenic shock. Shock means a lack of blood supply or a reduction of blood supply causing cellular and tissue hypoxia. This is caused by the pump failure, bradycardia or arrhythmias or myocardial rupture. So any other complications can end up causing cardiogenic shock in acute coronary syndromes. Moving on to the heart rhythm abnormalities, there could be the bradycardias or arrhythmias. Bradycardias tend to be more common with right coronary artery involvement or inferior myocardial infarctions. Sinus bradycardia is fairly common. Then AV conduction delays, including Morbid's type 1 or complete AV block, can also be seen. Various degrees of block can be seen. They can be transient, they can be persistent. So we have to keep a tab on those things. Tachycardia, sinus tachycardia is fairly common. There's a sympathetic overdrive during an MI, so patient will anyway have sinus tachycardia. Due to the same reasons, patients are predisposed to having tachyarrhythmias as well, including ventricular tachycardias. Some of these are more benign than others, and some of them can be fatal, including ventricular fibrillation and VT with shock. Myocardial rupture it's not very common nowadays with improved reperfusion strategies, but it still does occur in about less than 1% of cases. This can be a rupture of the free wall, or it can even be a rupture of the interventricular septum leading to a ischemic VSD. Clinical features again, patient will become suddenly unwell or will continue to be unwell without improvement. There will be sudden hypotension or shock. The patient might go into acute pulmonary edema. There may be a new onset murmur, and patient might crash suddenly due to tamponade. Ventricular aneurysm, I'm not going to talk too much about it. It's a bit of a medium to long-term complication. Not very common to see it early on. Okay, now this is the most important part. I think the most important part as healthcare professionals working in a cardiac setup, either in a CCU or in a high dependence unit in a medical ward, we have to, I think I can't emphasize enough the importance of a nurse in managing acute coronary syndrome. A nursing officer has a lot of responsibility, more so than even the doctor, because the first contact is always with the nursing officer. So that's why we have a CCU set up, so that we have more nurses per patient. So if we try to give one-to-one care, if not at least one nurse responsible for 2 patients. The reason for this is we need to have active surveillance, particularly in the first 24 to 48 hours. Most of the complications of acute coronary syndromes or the lethal complications occur in this first 24 to 48 hours. That's why most of our patients end up going to the coronary care unit or high dependency unit in a monitored bed in a medical ward. So this is where we look actively for any other complications that we just mentioned earlier. This is often called routine monitoring, but we have to remember that there is nothing routine about it. Active monitoring may be a better term because we have to actively sort out complications. It's not normal nursing care. This is going beyond the normal care, and so much so that in developed countries, cardiac nursing in itself is a specialty because that's how important the nursing care is to a cardiac patient after an MI. So what do we monitor for? So simple things. Monitoring does not mean only things that can be measured and written down. You should talk to the patient, see how the patient is. Is the patient recovering? Does the patient look better than when he came in? Important, has he developed chest pain again? Or does he complain, was he okay before and now he develops chest pain again? So if things like that you have to monitor, doesn't necessarily have to document all the time, but at least you have to keep a tab on the patient, and if the patient reports any chest pain, please escalate to the ward doctor or the consultant. Then there are recording sheets for blood pressure, heart rate, saturation, etc. Then the doctors are responsible for medical examination for clinical features of heart failure and new onset murmurs. Then there should be continuous ECG monitoring. That's why the whole concept of a CCU began in the 1960s and the 70s, just for the monitoring purposes. And that was a time when there was no thrombolytic or reperfusion strategy available. But compared to the 1930s, 40s, and 50s, when the coronary care units were first introduced in the 1960s and 70s, there was a marked improvement of cardiac mortality in acute coronary syndrome patients, despite not having reperfusion therapy at that time. So the reason there was because most of the patients end up dying because of arrhythmias. So if you are in a monitored environment in a coronary care unit, you will pick up the arrhythmias early and you can treat the arrhythmia. So if a patient survives that initial 24 to 48 hours without an arrhythmia, then the patient's short to medium term mortality is much better. So therefore, that is the basis of coronary care monitoring. So this is why, compared to a normal medical ward patient, a cardiac post-MI patient requires continuous ECG monitoring to pick up on any arrhythmias that we can treat. And you should always do an ECG every morning or at least twice a day, and whenever a patient reports any chest pain. So it's very important because in this day and age, with particularly those of us who are working in PCI centers or primary PCI centers, patients, if the patient develops new chest pain, it's very important to do an ECG then and there. True that the patient may be monitored continuously, but you need a 12-lead ECG every time the patient reports some chest pain. So that's very important to remember. A little bit about the management of complications. Dr. Sumudhu had already touched on these things. I will try to elaborate a little bit more. So most patients after MI, or at least some of the patients, will go into heart failure. So we recently started our CCU in the KDU hospital, so I'm sure some of us are so I'm very familiar with our new nurses getting used to the patients who present with florid heart failure. So it's an important complication. It's something that we can easily manage in the CCU setup. You start with the respiratory support. If the saturation is dropping, you give your oxygen via face mask. If that's not helping, you can then escalate to the next stage, which can include a CPAP. I'm sure most CCUs or even medical wards nowadays will have a CPAP machine, or BiPAP if needed, if it's a COPD patient, then intubation and ventilation. So simple things like if the saturation drops below 90% or 90 to 92%, picking that up and starting oxygen can be done at the level of a nurse. You don't necessarily have to escalate it. So if you see that the patient's saturation is dropping, start the oxygen and then inform the doctor Don't wait to inform the doctor and start the oxygen, because that sort of things can save the myocardium and save lives. Then offloading with diuretics, that's more of a medical decision, but still, as you gain experience working in a CCU, you will have a lot of experience you'll have a clinical feel for who needs offloading or not. So those are things that you should sort of get this intuition about managing a post-MI patient. If patient goes into cardiogenic shock, we start inotropes or vasopressors. Most of our nurses are very well versed with management of inotropes, on how to escalate and how to wean it off. And rarely, in advanced centers, we use equipment such as an intra-aortic balloon pump for mechanical circulatory support. Arrhythmias, if you get bradycardias or AV conduction block, if they are hemodynamically stable, if the blood pressure has not dropped, and if the heart rate is about 40 to 50, I think we can monitor. However, if there is a drop in blood pressure, then you need to certainly start on or give some support by means of using atropine or isoprenaline, or in refractory cases, escalate up to a temporary pacemaker. Tachycardia is usually physiological after an MI due to the sympathetic overdrive. However, if it goes beyond a certain limit, maybe very severe tachycardia, that can be that itself can be counterproductive. Therefore, we may have to consider beta blocker, particularly if the patient is stable blood pressure wise and not in heart failure. Little bit about more sinister tachycardias and arrhythmias. You can have VT, ventricular tachycardias or ventricular arrhythmias. Non-sustained VT or idioventricular rhythm are fairly common even in this day and age of reperfusion therapy. Sometimes reperfusion itself can lead to these arrhythmias. They are usually benign relatively, particularly if there is no drop in blood pressure. So we can just monitor. If it's lasting less than 30 seconds, or if the heart rate is less than 100, while having a ventricular tachycardia, it's usually safe. But you should escalate it to the doctor and the consultant, but you can sort of monitor those patients. Does not require emergency cardioversion, etc. However, if there is sustained ventricular tachycardia, then it's reasonable to start the patient on amiodarone or beta blockers. If there is any ventricular tachycardia with symptoms of instability, such as heart failure, hypertension, or worsening chest pain, then immediate DC cardioversion and start amiodarone to prevent a recurrence. If there's ventricular fibrillation, then you just go for immediate unsynchronized cardioversion. Then, so general considerations. So I'm not going to go deep into it. So I'll come to the last slide. So take-home message: the ACS is a high-risk condition, affects various functions of the heart. All those functions that we talked about. You can identify the complications early if you monitor the patient actively, and early identification can lead to better management and better outcomes for our patients. So thank you.
Thank you, Tamal, for that interesting lecture.